Hi, this is Brian Kim. I'm going to share with you case number 37 in the best way to do cataract surgery series. This is a patient who had weak zonules, which I was able to detect when I tried to do my puncture style Capsulorhexis. You'll see that the forceps never was able to puncture through the capsule, so I had to switch to the cystotome to finish the rhexis. I'm going to use a corneal marker to help me center and size my rhexis, and I'm using the cotton tip to help hold the eye steady. I'm going to hold the eye and turn it upward. I'm going to use a steel blade to make a flat paracentesis incision. Again, I'm flat to the iris plane, parallel to the iris plane to get a nice horizontal corneal shelf. I'm doing the same thing on the other side, using the cotton tip to help turn the eye, making a nice limbal incision, and then getting, again, a nice incision parallel to the iris plane to get a nice corneal shelf. I'm injecting some intracameral lidocaine and then dispersive viscoelastic. I'm doing my triplanar corneal incision. I'm making a vertical groove and then tunnel into the groove through the cornea and then dimple down. I'm using my cannula to help guide the eye as I do this. And this is the triplanar corneal incision. So I begin my puncture style Capsulorhexis. As I push down with the forceps, you can see I'm not able to puncture through the capsule. And so this is a sign of weak zonules. And so I'm going to switch to the cystotome to help me start the rhexis. And in the meanwhile, as I'm gathering my thoughts, I'm thinking about, okay, this is a weak zonule case. I have to be careful when I spin the lens to be very gentle on the zonules. When I disassemble the lens, I want to make sure I don't spin the lens if I can, do a no spin technique to minimize any zonular stress or trauma. Be very careful with lens disassembly, and when I pull the lens pieces up out of the bag, I have to be aware that the bag can be floppy and there is a higher risk for posterior capsule rupture. And so I begin my Capsulorhexis, and I go around circumferentially, again trying to use the corneal mark, which will help me center and size the rhexis. And I'm grabbing and I re-grab as I go every 2 clock hours or so. And this is a nice rhexis. And then I burp some viscoelastic. We're going to switch to the Capsulorhexis Hydra dissection technique, placing the cannula to the contralateral equator, pointing the tip down, getting a nice fluid wave, decompressing on the left side, freeing up the anterior capsule on the left side as well. As I try to turn the lens on the right side, I'm being very ginger, knowing that this patient has weak zonules, and I'm trying to be very careful not being too aggressive in trying to turn the lens in the bag. I put some irrigation on the cornea, and then I'm going to lift the incision with irrigation off to minimize Descemet's trauma, and then I go in. I'm going to remove the surface epinuclear material, place the chopper out to the contralateral equator, turn the phaco tip vertically subincisionally, crush the lens piece by turning the instruments vertically and crushing the lens piece with a double chop maneuver, placing the chopper out to the contralateral equator, pulling it centrally, crushing the right heminucleus, and this is the cross chop maneuver. You can see that first quadrant came up, and I began to use mechanical crushing forces to crush the lens, and then using high vacuum and bursts of intermittent ultrasonic energy. I turn the second heminucleus in front of me, place the chopper out to the equator, crushing it between the chopper and the phaco tip, placing the phaco tip fairly deep in the bag, grabbing the third quadrant with high vacuum, and then orienting it so I can crush the lens between the chopper and the phaco tip. I'm orienting the fourth quadrant in front of me, placing the chopper out to the equator, crushing the lens piece by placing the phaco tip deep, crushing the lens piece and sandwiching it between the chopper and the phaco tip. You can see this is not a super dense lens, but again, this is a case which is about a 1 to 2 plus dense lens. You want to be really careful with the zonule. So again, minimizing zonular stress, bringing the lens pieces up, crushing the lens with mechanical fracturing forces, chopping the lens where it is, rather than trying to turn the lens to meet the needs of my instruments. I'm chopping the lens where it is by using these techniques, double chop, cross chop, and mechanical fracturing techniques. Once the entire endonucleus is out, I try to remove a little bit of the epinucleus, but it's fairly stubborn. I push BSS with the cannula, take the INA handpiece out, and I'm actually pushing BSS into the Capsulorhexis trying to essentially re-Hydra dissect that lens material. And the reason I'm doing this is because I know this is kind of a weak bag. I want to cause minimum stress when I'm doing my cortical removal. Once I'm done with that, I go ahead and place the INA handpiece. And then I start subincisionally removing the cortical material, and then I'm going around circumferentially using high vacuum to remove the cortical pieces from the bag. I'm sweeping underneath the anterior capsule rim, but I'm being very careful using very minimal vacuum because I don't want to grab the capsule and tear the zonule. So you can see I switched to the polish mode fairly early. And this is kind of a medium-sized pupil, so when I'm going underneath the anterior capsule and I can't see it, I like to go in the polish mode. You can see I'm using the polish mode against the posterior capsule. There's quite a bit of very thin fibers there, which is fairly common when you have these weak zonules. It seems like the cortex doesn't come off as cleanly in these cases. So I'm just taking my time, going bevel down in the polish mode, getting occlusion and just teasing off those fine cortical material off the posterior capsule, as well as underneath the anterior capsule, as well as in the capsular fornix. So again, I'm sweeping side to side on the polished mode, so I'm very confident I'm not going to cause any zonular or capsular rupture doing this technique. And then I'm using the BSS cannula to pulse into the capsular fornix subincisionally first and then circumferentially. You can see that there's not much lens material coming out of the bag as I do this maneuver. And then I switch to the cohesive viscoelastic cannula, pushing the cohesive viscoelastic into the capsular bag, pull the INA handpiece out, and then I'm switching to the capsule sweep. I want to make sure I go into the capsule fornix as well as underneath the anterior capsule rim, removing any potential lens epithelial cells as well as cortical material. I'm sweeping on the left side and I'm switching to the right side now. Again, I'm polishing, making sure all that small amounts of lens material is removed and swept from the bag. Now I'm injecting my single piece acrylic intraocular lens into the capsular bag. And then with irrigation off, I go in, turn on the irrigation, disassociate the haptic from the optic, making sure the leading haptic is off the optic, and then the trailing haptic. I go underneath the optic, rotate the lens 90 degrees, tilting it so I'm under the optic, and I'm removing all the viscoelastic within the bag, and then reposition the lens, remove the viscoelastic from underneath the anterior capsule edge as well. And I'm using very careful foot modulation to make sure I don't use too high vacuum when I go underneath the anterior capsule edge. I switch to viscoelastic removal and I remove all the viscoelastic from the anterior chamber. I push BSS with my cannula to make sure any viscoelastic in the angle is removed. I pull the INA handpiece out and then I hydrate my incisions. So you can see in this case, this patient had quite a bit of weak zonules, which was indicated by my inability to puncture with my forceps style Capsulorhexis. This is actually a nice technique, not only because I like puncturing with the Rhexis for just a more efficient way to do the technique, but by doing this technique, I'm able to discover that there was weak zonules. So I was able to switch to the cystotome, continue the case, but I was very mindful about weak zonules throughout the case during my Rhexis, during Hydra dissection, spinning and loosening the lens disassembly, removing the cortical material. I made sure I was very respectful and careful of the capsular bag and the zonules throughout the case. So I hope this was helpful to you, and I thank you for your attention.